We know that the pectus journey is a unique one, and it takes a village. So my role in this is to answer your initial questions and help walk you through the pectus process. This Zoom webinar is something new that we're trying. We're doing it with the hope to spread some knowledge and awareness, as well as answer some of your questions. Ideally, this is one in a series of many webinars to come. We do plan on saving this presentation to our website, which is nestprocedure.com, as well as saving it to pectus.com. I just want to say thank you to Adam over at pectus.com for helping us get the word out on this as well. We would love to get your feedback afterwards, and also get some topics and ideas for topics for future webinars. So feel free to send me an email, info@nestprocedure.com. That contact information will also be on the presentation and can be found on our website. So with that, I'll pass it on to Dr. LoSasso. Thanks again.
Welcome and good evening. I'm Dr. Barry LoSasso. I'm a pediatric general surgeon and I practice in Paramus, New Jersey. I'm coming to you this evening from my home in Edgewater, New Jersey. It's great to have all of you, and I really appreciate your interest in the topics that we're going to discuss this evening. You know, the topics in pediatric surgery and in pectus deformities in general are so broad, they can be a little overwhelming. So I'm going to try over the next few months to do a series of webinars specifically on aspects of pectus and the correction of pectus. And I hope you'll join me as we go forward. You know, these are very difficult and somewhat strange times we're in right now. But something that I've realized in the last few months is that technology is really something that can connect us. For me and for Michelle, my wife, it's allowed us to stay connected to our friends and our family. And it has also allowed me to stay in touch with patients at a great distance. So it was that experience that led me to the idea of reaching out to the pectus community using this telecommunication format and doing webinars. So I hope that this will be one of many, and I hope you'll enjoy the information that I'm attempting to share with you, because I think information will empower you all to make the very best decisions regarding your pectus journey. So tonight, I'm going to be speaking about pain management and surgical rehabilitation following the procedure. I'd like to first describe to you a little bit about my background. I went to university at Yale University, and I attended medical school at the University of Florida. I then went to New York City, where I was born, and did my fellowship at Babies Hospital, Columbia Presbyterian Medical Center in New York. And following that, I ventured back to California, and I began my professional career at San Diego Children's Hospital then, and then subsequently Rady Children's Hospital. I had started my interest in chest wall deformities while I was still a resident in general surgery at UCLA with Dr. Eric Funkelsrud. And then that continued and deepened at Babies Hospital, there working with Dr. Peter Altman. When I left to go into practice in San Diego, I was doing the operation that was the only operation really at the time, the Ravage procedure. And patients came to me and I treated patients in that fashion. The world really changed in 1998 when Dr. Donald Nuss presented his series, 45 patients, roughly accumulated over a 10-year span, that revolutionized the surgical correction of pectus excavatum. And it did so by proposing a minimally invasive operation that did not involve the removal of any of the chest wall, but rather a novel way of putting a implant into the chest wall. And much like braces redirecting crooked teeth, this implant, a steel bar pushing the chest forward, then completely changes the configuration of the chest through a process of remodeling, changing the shape of the chest over the course of a 3-year period. When I heard Dr. Nuss give that lecture, I knew that the whole world of pectus surgery was going to change. And so I was one of the early adopters of the procedure. I went to Norfolk, Virginia, and over the course of about a year, I spent 3 or 4 times with Dr. Nuss, learning the operation, learning patient selection, learning how to care for patients, and that mentorship was invaluable to me. I went back to San Diego at the end of that year and began doing the Nuss procedure. And that was in 1999. I did my first case, 20 years ago. It seems like just yesterday. And then in 2006, I was being approached by so many adult patients with this problem that I decided, if not me, then who? And I said, I'm going to begin an adult program. And I did so at the Sharp Memorial Hospital, which is right next to the Children's Hospital in San Diego. Next slide. So in the 20 years since that first Nuss procedure, I've done over 1,000 Nuss procedures and a few or more of bar removals. So over 1,000 both of insertions and removals. And the patient range has been from the youngest, which was 12, to the oldest, which was 52. About 20% of my patients are adults, meaning over 18. In 2017, I moved my practice from the West Coast to the East Cost. You might ask, well, why would you do that? Well, I have a great reason for doing so. It was to join my mentor, Dr. Rajdir Gandhi, who trained me at Baby's Hospital, and his partner, Dr. David Friedman, in practice in Paramus, New Jersey. And that opened a whole new world for me, a world of new colleagues and exposure to new trainees that has just been so rich and rewarding. I do all of my pectus surgery out of the Valley Hospital in Ridgewood, New Jersey. I operate there on both children and adults. And this is a picture of the front entrance to the Valley Hospital. Next slide. Tonight, I'd like to go through an overview of pectus so that everyone tuning in will understand what pectus is and the different forms that it takes so that you have a basic fund of knowledge. Second, we'll get into pain management, both historically and some things that I do that are quite novel and I think helpful in relieving the discomfort that comes with having the surgery. And then finally, once you've successfully had the operation, how do you recover long-term? What kind of physical therapy and rehabilitation can you undergo that will help you achieve your best outcome? And then at the end, I will have a question and answers section where you can ask me questions and I'll respond. I'd like to keep the questions broad-based. If you have specific questions regarding your situation, then please reach out to me in a more private way, in private setting, so that I can address those questions in a way that preserves your privacy. Next slide. So pectus is a genetic condition you have to understand that this is something that you inherited. Even though you may not know the exact family member that has the condition, somewhere in your genetic background, someone had some form of pectus. And that genetic information affects a very specific part of your chest wall. In the front of your chest, your ribs are made of cartilage, the same substance that shapes the tip of your nose and your ears. That special substance is only found in the front of your chest. So as one grows, this genetic information then causes that cartilage to grow abnormally and excessively. And as it grows excessively, it causes the chest to do one of three things. Either it sinks, which is called pectus excavatum, or it protrudes, which is called pectus carinatum, sometimes referred to as pigeon-chestedness. And then in a very rare situation, a little bit of both can be in the same patient, the so-called mixed deformity called pectus arcuatum. This is a very common set of deformities. Pectus deformities occur in 1 in every 350 to 450 people on the planet. Just to give you some perspective, that's about twice as many people per capita as have cleft lip and palate. So it's a very common deformity. It's not always obvious because it's hidden under clothing, but it is a very common deformity, and it affects men more than women. So 4 men to every 1 woman has this condition. Next slide. So I'm going to give you a little advice starting off this conversation. And that advice is simply this. Your most important responsibility as a patient or as a parent is to choose the surgical specialist and his or her team very, very carefully. Because even though pediatric surgeons are, as a community, superbly trained surgeons, not all of us emphasize chest wall deformities in our practice, and some do more of this work than others. What you want as a patient and as a family member is to choose someone who does this as a matter of their practice focus. This is a passion for them. They do it often. They do it across a wide variety and spectrum of deformities. So they're doing it at a very high level. And equally important, it takes a village. So these individuals should have an entire array of specialists in a multidisciplinary team that surrounds them. And that includes nurses who care for pectus patients, anesthesiologists who work with surgeons to ensure that anesthesia is given properly, pain specialists, which we'll get to later, who know what kind of issues the NUS procedure can create for a patient and how to treat them, physical therapy and a physical therapist who can then assist you to get the ultimate outcome, and last but not least, an office staff who is equally committed to the care of patients with your condition so that the continuum of care is done smoothly and efficiently. Again, it takes a village, okay? The next piece of advice that I'd like to give to you is that the day of surgery, though extremely important, needless to say, is just one day. It's one day in a continuum of care that can last 3+ years. So it's important to understand when you're choosing someone to entrust your care to, that you keep that perspective, that you're actually choosing someone who you're going to have a very, very profound professional medical relationship with for years. And so that should shape the decision-making in terms of who you entrust with your care. Preoperatively, the continuum starts with radiology to assess the severity of your deformity and begin to develop a roadmap for the surgeon so that they can understand how severe is the deformity and how is it affecting your internal organs, specifically and most importantly, your heart. So there are radiologists who do this. They're skilled in interpreting chest radiography and specifically chest MRIs, and they're capable of really giving the surgeon tremendous insight into how your specific deformity is affecting your heart. In addition, a cardiologist needs to evaluate you to make sure that you don't have any other cardiologic problems, such as valvular issues and or issues with the major blood vessels around your heart. Also, is your conductivity normal? Is the electrical system of your heart operating normally? A pulmonary specialist needs to make sure that you don't have other associated lung issues and or diseases, the most common of which can be asthma. And you need an allergist to evaluate you because we've learned that the implant, which is stainless steel, has about a 13% incidence of people who are actually allergic to it. So you don't want to put something into the body that an individual may be allergic to. So an allergist should do a complete battery of allergy testing to make certain that the components of the stainless steel bar you're not allergic to. And if you are, then a titanium bar should be ordered and implanted. And lastly, there is a very small percentage of you with this condition that will have it as part of a genetic syndrome, collectively called a connective tissue disease. And for individuals who overtly look like they may have that kind of a body shape, or a history of that in the family, or during the course of your workup, you're found to have issues with your heart or with your eyes that might suggest that you have a connective tissue disorder, then a geneticist should also be engaged to do genetic testing and ascertain whether or not you are one of those rare individuals that have both pectus and a genetic connective tissue disease. Lastly, postoperative care. Postoperative care is extremely important, and the reason why I chose it for my first webinar is that often this is neglected. You'll come, a surgeon will discuss how he's going to do the operation, where the bar goes, how many bars, but he or she may fail to tell you that it's just a single day and that you have a 3-year journey that needs to be optimized. And that acutely means manage your discomfort well and get you back to a point where you can move and you can function pain-free. And then to optimize what the bar is doing for you by working on the increase in cardiovascular performance and strength and flexibility that we all ultimately want you to achieve, and that comes through physical therapy and hard work. The end of the journey is really bar removal, the end of the clinical journey with someone like me. And that is a very important decision when the bar is removed. You know, we sort of in general say 3 years, and for most people, that's in fact the answer. But the important thing for all of you to know is that this needs to be individualized. And some people who have a very severe deformity very early in life might get a bar implanted at 13 or 12. Well, at 15 or 16, 3 years later, that individual is still potentially growing and growing a lot. So you don't want to remove the bar at that point in the continuum of care. So in that individual, you would delay the removal of the bar. So that's why it's so important for your provider to stay connected to that individual and to realize that there are criteria that we've established for the removal of the bar. And that is an individual decision. In addition, it's so important to understand that the bar needs to come out. It is there for a period of time in which it does more good than harm. But that changes after the chest has assumed the corrected position. At that point, there's more potential harm than good. So for those of you who might be out in the audience, you've undergone the procedure, you have a bar in place, and you've lost contact with your surgeon, it's important to know that for your own safety and well-being, the implant needs to be removed. And who is the best person to do that? Unequivocally, it's the person who placed the bar. And why do I say that? Because there is variability between surgeons with regards to how bars are placed, how bars are secured, what the initial strategy was in how many bars and where they should be within the chest. And that is critical to know at the time the implants are removed. So optimally, you want to go back to the person who placed the bars to have them removed. Next slide. So in general, this is a fact of life. If you have major surgery, you're going to have some degree of discomfort. Pain is going to be part of that experience. The important thing, and this is the silver lining in that gray cloud, is that an experienced team, someone all of you should have caring for you, should be able to have a plan to both minimize and manage this reality. And that is why I chose pain management as my first topic. Next slide. So, I want first, could you back up one slide, please? I want to first look at pain management historically, because Dr. Nuss had a fantastic way of treating pain circa 1999. He came up with this novel approach which combined the placement of a small little tube in the epidural space, an area between your vertebral bodies and around your spinal cord, that allows the placement of either narcotics or local anesthesia that then numb the chest. And you combine that with opioids, narcotics. And that worked very well for its time. But the placement of an epidural catheter has some potential risk. And so those of us who who want to minimize risk, and Dr. Nuss led the charge on this, decided that there should be less potential risky ways of managing pain. So that then led us to eliminating the thoracic epidural and going to, next slide, what we now do, which is, back up one, please, which is a multimodal approach. What does that mean? Well, that means that we're going to use different types of medications that work in harmony with one another to attack pain from a number of different perspectives. Opioids are definitely still part of that equation, but here's what's changed. The opioid epidemic, that's what's changed. And what we want to now do is use it immediately after surgery and for as little time as possible once you're discharged from the hospital. Most of us try to limit that to 1 week after surgery. Well, how do we do that if it was such an important thing to use historically? Well, we use other medicines to complement the use of the opioid soon after surgery. We use things like gabapentin and Neurontin, which are anticonvulsants, which affect the transmission of the pain stimulus. We use muscle relaxants like Valium, benzodiazepines, to reduce the spasm that occurs within the muscles of the chest wall and back when abruptly the chest wall is pushed into a corrected position. And we use non-steroidal anti-inflammatories, the most common of which is ibuprofen, otherwise called Advil or Motrin. And there are some designer NSAIDs like meloxicam and Celebrex that can also be used. So there's this continuum of anti-inflammatory meds that complement the muscle relaxants and the neurolytics and the opioids to achieve a better control of your discomfort without relying solely on opioids. Next slide. So who does what? What role does the surgeon play, and what role does the pain specialist play? Well, in my opinion, the surgeon's role is to do the best operation technically that can be done. And that means make good decisions. Make good decisions about how many bars and where they're placed in the chest. Precisely bend the bar. This is the part of the operation that I love. It's the art of it all. It's the bending of the bar, sculpting it in a way that it fits perfectly into the chest and achieves that perfect functional and cosmetic result that both you and I want. The next thing is minimize trauma. Surgery is traumatic. It can cause injury, but it's important to know. It's important to know that by minimizing that discomfort, it will cause less pain to the patient. Am I still on? I've lost.
Yep.
Good. Can you give me the, I'm sorry, there we go. Okay, thank you. My screen just went through an update. So minimizing the handling of the tissue is very important. And of course, avoid complications. That's true for any surgery, but in this operation, it's very important. You're operating within the chest, and you need to be careful to minimize bleeding, infection, and any migration of the bar. What role does the pain specialist play? I think it's important to understand as a patient that everyone's pain perception is different. So to some degree, a pain specialist needs to assess your pain history, your expectations with regards to pain and this procedure, and then use that history taking to devise a specific plan for you, using the medicines that we just discussed, but using them in a way that is specific to you and you alone to achieve the very best outcome. That strategy has to be arrived at before the day of surgery and then amended as events occur and as things evolve after the surgery. But that assessment is vital before the day of surgery. Next slide. I want to share with you tonight something that I do that is unique. I believe that some direct nerve block is essential in reducing hospital stay and reducing the need for narcotics in managing one's pain following surgery. I was introduced to the medication called Exparel, which is a local anesthetic, which all surgeons use, but packaged in a very, very creative and unique way into what's called a liposome, which is there on your screen as a graphic figure. And what Exparel does is it takes a very, very powerful local anesthetic, much like what the dentist would use to block the nerves that would allow a painless dental procedure, to be delivered into the chest wall and released over time. So what you have is you have a very powerful local anesthetic blocking the nerve, and it lasts for 3 to 4 days. That's a very, very potent and helpful pain management strategy to have. Now, what it does is it allows you to use the telescope that's already being used to do the NUS procedure to direct a needle to the area where each of the nerves run under the rib. And by directing the medication to where that nerve is, you can block that nerve, and you can do it on multiple ribs on both sides of the chest and accomplish almost a near total, what we call rib block, on both sides for 3 to 4 days. What is good about Exparel and why I love it so, and why I think it should be used by more surgeons doing the NUS procedure, is that it reduces opioids, it reduces any direct injury to the nerve, because I'm not freezing the nerve or injuring it in any way. I'm just blocking it pharmacologically using medication, and a medication that we use to, numb areas of the body all the time. And most importantly to you, the patient, it reduces hospital stay. Next slide. So physical therapy, I think this is the one area that we as surgeons sometimes neglect. I think this is absolutely crucial for every patient who undergoes a NUS procedure to commit to doing. And that's why I want to say, first and foremost, it requires a team, but you're at the center of that team. You're the most important member of that team, and you have to advocate for yourself to make sure that you have physical therapy and you undergo rehabilitation once you're discharged from the hospital. That's crucial. That's crucial if you have your surgery in New Jersey or you have your surgery in California. Regardless, it is, I think, next to the actual doing of the operation, the most important part of optimizing your outcome. And what does it entail? It entails a 16-week program that essentially and broadly based allows for increased mobility and strength and flexibility through exercise. Okay? On my website, I have a detailed protocol for physical therapy. I arrived at that protocol through collaboration with physical therapists. And that physical therapy protocol is not only in written form on my website, but it also is in the form of a video that doesn't show every exercise, but it shows the most important exercises. And it gives you a feeling by watching the video of what sort of exercises you need to do in order to optimize your outcome. I would ask that you all visit the website, if for no other reason than to review the physical therapy video and to familiarize yourself with the kinds of exercises that will optimize your outcome. This is important. Physical therapy can be done locally. Wherever you have the surgery, if it's different from where you live, when you get back home, you need to make certain that part of your ongoing team includes a physical therapist. And as equally important is the fact that not only are you going to do physical therapy with the therapist, but you're going to do what you did in the therapy office at home. So my plan and what I try to get my patients to commit to is twice a week with the physical therapist, and twice a week you do it at home. For a total of 4 days a week, you do some form of physical therapy. Next slide. So in week 1 through 4, you're going to be just doing breathing and stretching and sort of postural retraining. What does that mean, postural retraining? Well, it means you have to grow into the new posture that the bar is actually forcing you into. And that can be a little uncomfortable and it can be a little challenging. But through stretching, deep breathing, and some manual therapy that the physical therapist can provide to you, which is sort of gentle massage, but it's really sort of gentle motion, get you and your body to feel comfortable in this new posture that the bar has caused you to assume. In weeks 4 through 8, you're going to be doing cardio training, and you're going to be working on your shoulders and your back by doing scapular and rotator cuff strengthening. You're going to do core exercises, and I want to really emphasize this, that your core and the strength of your core will have so much to do with your skeletal alignment and will have a lot to do with your chest, shoulder, and back posture. So you can't have a good chest and back posture without strong core muscles. So that needs to be addressed, and it is in my physical therapy program. And in weeks 8 through 16, you'll push forward with your cardio training. You'll start to do actual muscle strengthening exercise, and you can even begin to do sports-related therapy as you get closer and closer to that 16-week finish line. Next slide. In general, and these are just general guidelines, and I would just caution you to sort of assume that this is absolutely fixed in stone. This is just an outline. It's something that should begin a conversation between you and your team with regards to how you get back to doing the things you love to do. So there should be some modified return to physical education classes at 8 weeks with no contact sports. And there can be unrestricted return to aerobic exercise at 16 weeks. And an unrestricted return to sports, including contact sports, at 6 months. Excuse me. Some surgeons feel that 6 months is not long enough. Some surgeons feel that contact sports at 6 months is waiting too long. So I think there's where individual surgeons have individual bias, and you'll have to speak directly to the person who is providing you surgical care to see how he or she feels about that ultimate goal. I know in dealing with a lot of professional athletes in my practice, that they're highly motivated to get back to doing the things they love to do, and they want to do so sooner than 6 months. And in some of them, where the physical therapy has gone well, they were already in excellent condition prior to the surgery, that can be accomplished. So there is room for individualization. But in general, for me, I advise my patients who want to engage in contact sports to wait a full 6 months before doing so. Next slide. So this is the point where you can get involved, where I'm here to answer your questions. And while you're thinking of those questions, I'm going to go through a few questions that were actually sent to me prior to the beginning of the webinar. Well, I wanted to go into a few questions were based on bar removal. So I wanna address some of those questions at this point in time. I think we talked a little bit about why the bar or bars need to be removed. So there were a lot of questions about that you sent in to me. If you have any additional questions, please feel free to ask. Some people asked about pain control following bar removal, and I think that's a very important question and one that I'd like to address. So bar removal is actually an outpatient procedure. It's intrinsically not as painful as bar insertion. And it takes less time in the operating room, and your expectation should be to go home after the bar or bars are removed that very day. And the way I manage this is I again use Exparel. I find that Exparel is excellent to be used around where the bar used to be in the chest. And I can use that drug to block the area where I had to open tissue to access the bar. And I use it around the incisions, which were the original incisions used to insert the bar. I put more of this medication in that area to numb that area. And I have found that the need for any narcotics has been greatly reduced. I do give some narcotic to go home with. I usually give no more than what would be used for 2 to 3 days, depending on, the assessment that the patient and I have about how they managed pain originally. But generally, 48 to 72 hours of narcotic is all that's really necessary to successfully get someone through the acute phase of pain management following bar removal. And then thereafter, you can use Tylenol and Motrin in combination, and be very, very comfortable. Most people return back to, work, especially if work doesn't entail a lot of physical labor, within a matter of days. If you do tend to do a lot of physical labor, or your job requires a lot of physical work, then I say usually it's 2 weeks, and you should be able to be comfortable returning to that. A lot of people are asking, what are the chances that my chest, once the bar is removed, will once again sink and become sunken? And the answer to that is, in my experience, I have never had a recurrence. So if you go to somebody who is experienced, you achieve a good result with the NUS procedure, the bars are left in place the appropriate amount of time, you should assume that once the bars are removed, your chest will remain in that corrected position. Does that mean that that correction is perfect? Not necessarily. It's the best that could be achieved given the specifics of your deformity, but that result that you've achieved at the end of that interval of time, whatever it is, 3 or 3+ years, should be the configuration of your chest forevermore once the bars or bar is removed. That should be your expectation. And quite frankly, don't worry that that expectation won't be met, because it will. There are other things to worry about. Don't worry about that. The next thing is, what is life like after bar removal? Well, we were talking as a team about where we want to go with this webinar, and I really think that life after bar insertion is something that I really want to talk a little bit more about in depth, because I think that there are so many questions and concerns amongst the community about that. But in general, I would just like you to know that once the bar is removed, the correction is complete. There's no further changes that should occur skeletally with your chest wall. That process has run its course, and your chest is going to be that configuration forevermore. Now, you can lose weight, gain weight, increase muscle mass, lose muscle mass. There can be changes in terms of the soft tissue, what we call the soft tissue of your chest. But the actual skeletal correction is permanent, and that should be your expectation. In addition, you shouldn't expect that once the bars are removed, that you will feel anything but progressively better. Not immediately. There is recovery from removal of the bar. It's like any other operation. There's some trauma associated with bar removal. But those uncomfortable feelings that you might have felt when you sneezed or you coughed or you laughed, those kinds of things, and that restriction, that slight restriction that you feel when you're doing something that is very exertional, that goes away. How long does it take for that to go away? In my experience, it's somewhere between 3 and 6 weeks. Most people, by the time they get to 6 or 8 weeks after bar removal, they feel a sense of freedom and liberation and a sense of well-being in their chest that they really haven't felt, some ever, but surely since the bar or bars were inserted. So that should be your expectation. There's a period of adjustment and healing after the bars are removed, but ultimately at about 6 to 8 weeks, you should feel as good as you've ever felt, especially when you're doing things that involve exertion. There were a lot of questions about 1 bar versus 2 bars. And I just want to say a little bit about that. I don't want to dwell on technical things tonight, but I know that's a question in the community. And I would just like to tell you this, that that's why you go to an experienced provider. That is an important decision that is based on judgment and experience. And so you want somebody who does a lot of the surgery on an ongoing basis, both historically, meaning they've done a lot in the past, and they continue to do a lot of it prospectively, so that you can be assured that your surgeon has seen the entire spectrum of pectus deformity and can tailor-make the proper repair to your individual condition. And that is where judgment and experience come into play. Knowing where to put a bar or bars and how many bars to position in the chest is really a critical decision-making that is based on experience. In general, you want to put the first bar under the deepest part of the deformity and then use how the body responds to that to determine where a second bar or further bars should be positioned in the chest. And you use the information you gain from thoracoscopy, meaning looking through the telescope that's in the chest, to make that decision, because you can see how the body responds to that first bar in terms of where is the chest wall and where is the heart. And you also, of course, can look at the external configuration of the chest. And that combination of observations allow you then to decide, is more than 1 bar necessary? So that is the group of questions I received. So I'm open to other questions from those of you in the audience. So please, Kate, allow people to ask their questions. And thank you for your questions.